great to see everyone on this lovely June morning. And we're here, obviously, at an amazing time. Perhaps it's always an amazing time for healthcare in Massachusetts. But this is especially acute, if you will forgive me the pun. It's an especially acute time to have not just this discussion, but these two discussions. I'm Craig Sandler, the managing partner of the State House News Service, which runs the State House Forum in conjunction with MasterList. Delighted to see everyone here. Really excited that we have two groups of excellent panelists. Just to give you the order of business, you're probably familiar with it. Our first panel will talk about legislation and the current state of play in the legislature in terms of healthcare, and then we'll move on to the hospital healthcare provider industry landscape. So we'll begin with our first panel. We're really more or less riveted. Of course, I'm a journalist first, and that's the right word, more or less riveted to have the chairs of the Healthcare Committee in the legislature for our first panel, Senator Cindy Friedman and Representative John Lawn. We're really looking forward to hearing what they have to say, both, of course, about the next month coming up, but also about the coming years and where we really are. That panel will be moderated by Katie Lannon, our outstanding reporter at the State House News Service for the time being. And we are really looking forward to that discussion. Before we get to it, we obviously have to thank our sponsors, without whom we would not be here: the Mass Health and Hospital Association, the Healthcare for All, the Mass Association of Health Plans, Mass General Brigham, and Tufts Medicine. Just as impressive as the panelists are, that collection of sponsors is really impressive too. We're sort of gratified and grateful to our sponsors. And so with all of that, I'll ask Katie and Representative Lawn and Senator Friedman to take the stage. We'll get you mic'd up and give the audience what they really came here for, not me. But thank you for being here.
Thank you, everyone, for joining us this morning. Thanks to Senator Cindy Friedman and Representative John Lawn, the chairs of the Healthcare Financing Committee, coming to chat with us this morning on what, those of us in and around the State House know to be an incredibly busy time of year. We appreciate you taking the time. So let's chat a little bit about what you've been up to. We've seen a lot of healthcare legislation moving in Beacon Hill this session. Let's talk about what each branch has done and what your priorities are. Representative, what's been going on in the House with healthcare?
Sure. Thank you, Katie, and thank you to State House News and for all the sponsors here today. We appreciate it and look forward to this conversation today. As you said, my name is John Lawn. I'm from Watertown, and I am the House Chair of Healthcare Finance. I think some of the legislation that we passed that was, I think, in the news quite a bit last year was the DON process that we took up to make sure we strengthen our community hospital systems and
that's determination of need for anyone who's not up on their alphabet of healthcare acronyms.
Right. Which really was to expand and strengthen the material change notice process and really to expand that for transactions and to give Health Policy Commission more information on healthcare expansions throughout the Commonwealth. We also, in that legislation, was established a health policy. So to understand, the Health Policy Council, so we could actually take a good inventory of what we have in healthcare across Massachusetts, so that we really can make educated decisions in further DON processes. So that is something that we took up. That was, I know in the news, it's something we have some great medical and hospital systems here in Massachusetts. And when Chapter 224 was done, it dealt with a lot of mergers in hospitals and not expansions. And this is something that we really feel like we need to protect our community hospitals and make sure when a larger hospital system goes into a territory, that does not have a negative impact on a community hospital and a safety net hospital that are so important to healthcare in so many areas of the Commonwealth. And I think many of you know, while we are always working to try to maintain and provide access to healthcare here in Massachusetts, there are so many challenges when there's an expansion into a territory. So we really did that to protect our community hospital system, which plays a vital role in bringing affordable health care to many areas of the Commonwealth. I also know that when a hospital goes into a territory, we see so many hospital costs that are arising and the challenges that our healthcare system is facing. Where another concern there too is a workforce challenge that we have. When they move into a territory, they're going to be drawing employers away from another healthcare system and paying higher rates. So those are challenges that we have in the legislature to make sure that we have affordable and accessible healthcare to everyone. And that's our challenge. It's not to punish one system, it's to make sure we are thoughtful in how we expand healthcare in Massachusetts.
Great. And Senator, I know cost and access have also been on the minds of senators across the hall. A little bit of a different focus area than your counterparts in the House. Why don't you tell us a little bit about what the Senate has been looking at in healthcare?
Sure. So we've been, we got a DON bill from the House, and it's a good bill, and we've been looking at it and actually recently focusing on it. But in addition, we passed the step therapy bill. Of course, you know about our mental health ABC 2.0 bill that we did last year, I think now. Which is newly in conference committee. Which is newly in conference, just went into conference. So we're looking forward to that. Another piece that we focused on, which is of real critical importance, I think, to the cost and access, is the pharma bill, which addresses the issues around pharmaceuticals, bringing them into the cost trends hearing, and pharmacy benefit managers. Also, very important that we start to get a handle on the role that they're playing. And really what we've been focusing on in the area of access and cost is bringing all the players together under one roof, so to speak, so that we can really get an understanding of how this system is playing out and who's responsible for what role, and how does that all work together in terms of access, quality, and care. We also did the ROE Act. Both branches did the ROE Act, I think last year. So that's something that we did, and we did it fairly quickly. I think those are the big ones that we've been working on. And there's lots more to do.
And just to follow up on step therapy that the Senate did, the House will be taking up the step therapy bill tomorrow.
Oh, that's
yeah.
You heard it here first.
Yeah. So it's a lot of work has been going on, and a lot of stakeholders have been involved in this for many years, and it's a great bill that will help with patient outcomes and make sure that people don't have to go back and start on drugs that don't work for them. So it's a great bill. The Senate did it, and we will be taking that up tomorrow.
Great. And I think the other thing that we probably need to point out, which isn't a direct policy, but the amount of money that we've put into workforce in terms of, and again, this is a Senate and House piece that we did through ARPA, was the over $120 million that we put in for loan repayment from psychiatrists to primary care physicians to nurses, all the way down the ladder or all the way up the ladder of workforce, to get loan repayment to people, to bring them into community-based systems, to bring them into community health centers, so that we can start to address this very, very serious workforce issue that we're all facing in healthcare.
Yeah, let's talk about workforce for a minute. We're obviously 2 years and change now past the onset of the pandemic. the challenges that the healthcare system has been facing have shifted and changed along the way, but clearly no one's out of the woods yet. Workforce, I think, is one of those lingering issues. What do you see as the challenges that are still facing the healthcare system from the pandemic, and what can the state do about it?
Well, I mean, it's a great question. It's a challenge. We know workforce challenges in every industry, but our challenge is really in healthcare with the workforce challenges is we had, I think last October, we had 350 psych beds that were offline because we didn't have people to take care of people in the beds. We know we have over 20,000 open positions in our hospital systems right now here in Massachusetts. And how are we going to deal with that? We, in the budget, just a few days before our House budget, I was having lunch with a man who owns several nursing homes, and he was talking about the challenges of nursing positions that he could not fill. And he was talking about trying to get nurses from the Philippines. I represent a part of Newton, which is not in my district, but when University of Massachusetts purchased the old Mount Ida College in Newton, it is a campus that, to me, is completely underutilized. It was before the pandemic. UMass Amherst has not really, there's very just small programming going on for less than 100 students. And as I thought, and I filed an amendment to the House budget, was maybe having a study done to really take a look at that campus and can we do more to turn out more healthcare related jobs that we are drastically in need of. I know I think the last time I heard, we have over 56 or 700 open nursing positions right here in Massachusetts. And that's a very complicated problem that is not a simple solution to it. When I spoke with UMass Amherst, they have a program in Springfield that's very small, about 100 students, which is the second degree in nursing. So if you've already have your bachelor's and you have a lot of the prerequisites, you could go to a 16-month program and become a nurse. I think that provides an opportunity maybe to look at some of these things that we're going to have to do differently and outside the box of thinking how we can get more people into the workforce, and whether that's tuition reimbursement, do we get sponsorships from the hospitals or nursing homes. And that 20,000 doesn't even come into our nursing homes and other behavioral and mental health positions that we have open. We know we have to pay more. We need so many people to come into this profession, and unless we incentivize it and also take care of the existing workforce that we have. One of the things I know we'll hopefully get done this session is a workplace violence. We really need to send a message, and this is something the Senator and many others have been working on for quite a long time in many sessions, is really to send a message to our healthcare workers that we have our back. They're 5 times more likely to be assaulted on their job. We saw, this great resignation after the pandemic of people who are just completely burnt out of healthcare. My wife's an ICU nurse. I see it there. I see, how that's affected her. I see how it's affected that you go into work, you never know when you're going to get out of work. They working 14-hour shifts. They're burnt out. We need to take care of the existing workforce. We've got to come up with innovative ways to get people into the workforce and keep them in the workforce. So that's a challenge. We have the best healthcare system in the country. I know we have a dedicated legislator to work on these issues, but it's going to take many stakeholders to work together to solve these issues. So the workforce challenge is really something that we really need to pay attention to and work together with all the different stakeholders.
Yeah, Senator, I know you mentioned the ARPA investments. Anything on your mind on the workforce front as well?
Yeah, so we all know this is, in many areas of healthcare, this has been a problem long time brewing. And it's just been exacerbated by the pandemic, but it's been there for a long time. And we all know how we have a real issue around rates for primary care physicians. We have, for people who work in primary care, it's a big issue, the rates, and certainly our behavioral health system has been an issue for a very long time. So we have to focus on getting those rates. And I think for me, the issue becomes not so much putting more money into the system, but in actually moving money within the system so that we're focused on those parts of healthcare that actually make a difference for people, that address social determinants of health, that meet people where they are, that ensure that they get wellness care, that they get care before they get so sick that they need to be in the hospitals. But it's also something that we've been looking at very carefully is what are the barriers to providing care? I mean, it's not just money, but it's the incredible, administrivia that our healthcare workers have to go through, that they don't have scribes, that they have to meet all of these qualifications and all of these reporting structures where we haven't really looked at, do we need them? Are they important? I mean, one of the things that we've been moving toward, certainly in the mental health space, is can we have one credentialing system so a provider doesn't have to meet this credentialing requirement for this payer, this one for this payer. You know, it's just a continual slog of trying to just get their work done and get paid. We really, really have to focus on that. So it is absolutely cost, but it's also how do we get people back into the business of care and less into the business of administration. And I think we've tried to do that in our mental health bill. We certainly have been looking at, we have provisions in the care to look at what are the quality measures so that we can all agree, so that people aren't spending their time trying to get prior authorization, having to go through a different rigmarole every time they want to provide care to a patient. So I think that's something that we really have to focus on. And that again means that we need a system, and maybe it's the Health Policy Commission, which really has the ability to understand the work that everyone is doing, that everyone is within that umbrella, so we can look and say, well, how does this work? How do the insurers decide prior auth? How does the hospital pay for ambulatory care? I mean, it's across the board to understand what is pharma doing? What are the PBMs doing that are causing this incredible amount of money going into a system while people get less well?
Now, Representative Lon, you mentioned the budget, and of course we're a couple days off the new fiscal year. We don't have a final state budget in place yet. It's still in negotiations. When the House this spring took up its budget, it included, I believe, $500,000 around reproductive health access, infrastructure and security. The Senate in its budget bumped that figure up to $2 million. Given the timing of our conversation in light of the Dobbs ruling from the Supreme Court coming down on Friday, I think we'd be remiss not to discuss this element of healthcare. Senator Friedman, I think it was actually you spoke on the Senate floor about some other measures the Senate took in their budget. Can you tell us a little bit about what you're looking to get in the final spending plan?
Sure. So just a little background. The House did their budget and sent it to the Senate. And while that was happening in the Senate, the Alito ruling got leaked. So the Senate, having the budget, was sort of in the position to do something at that moment because we had the budget and the House did not. So what we looked at is not knowing what was going to come down, sort of knowing, but pretending or hoping beyond hope that it wouldn't happen. We put together an amendment that is basically what we call a provider protection amendment. And as you all probably know, the laws in Texas and Oklahoma and places like that are not only limiting a woman's right to control her own health care and her own body, but they also have provisions that private citizens can sue people who are getting an abortion, who are helping with reproductive care, who are providing abortions, all of that, the whole kind of plethora of things that happen when a woman goes to get care. And so what this amendment does is to the extent possible and under our Constitution, the federal Constitution and regulations, will protect our providers and people who support people in any way in receiving reproductive care. It will protect them within the state of Massachusetts as long as they're following the laws and good medical practice. So this does not allow people to usurp our laws and our regulations, but if they're following them, then this amendment is there for the purpose of giving them some level of protection. It doesn't allow liability insurance to go up. It doesn't allow it to affect your licenses. It doesn't allow the governor to do anything beyond what he's federally required in terms of summons and things like that. So he can't send somebody back to Texas to appear in a court of law unless there's very, very, very clear process that's followed. So while we can't stop this totally, we don't have to make it easy. And we want to do everything we can to protect people in this Commonwealth who are following the laws of the Commonwealth and doing good medicine. So that's what it does. And now it's in conference.
I know the Speaker, Mariano, myself, and all our colleagues in the House are very committed to making sure we have that protections for women in the state. We did act swiftly last year when the makeup of the Supreme Court changed and protected women here in Massachusetts and providers, and we'll continue to do that.
Yeah, and we've seen a similar executive order with the idea of provider and patient protections coming down from Governor Baker pretty quickly on Friday. And the governor, I believe, indicated yesterday he'd be supportive of some sort of reproductive health care funding in the budget. So that's really becoming, and Speaker Mariano had floated before the ruling came down the possibility of some sort of additional package to address abortion care and reproductive health care access. So I guess stay tuned. That's a late session add to the agenda coming out of Washington, D.C. And certainly we've talked about quite a few things that are moving from step therapy, workplace violence. We've got mental health care under negotiation. The House and Senate have both passed bills. By my last check yesterday, there's still about 4 dozen bills in your committee and plenty more that have been reported out and onward in the legislative process. Anything else you think we can expect to see start moving as we approach the final 4 or 5 weeks? Or is the legislature's healthcare agenda pretty much settled at this point?
Well, we would be a fool to think that anything is settled, right? Because you just never know what's going to happen.
Always something else.
I think we're committed to getting as much done as we can. What I think I forget, and perhaps my counterpart forgets, is there's other things to do in the Senate besides health care. Now, I don't know why, I don't understand, but we could fill the next 6 weeks with health care easily. The question is, how do we fit it in with all of, we have economic development, we have transportation, there's a number of infrastructure bills, there's a lot that's happening, and when you get 6 weeks, left, so I can't answer the question because I don't know, but we will keep trying and hope springs eternal.
I do think, we are looking at hopefully, doing some more on, as the Senator mentioned about pharmacy benefit managers in the House. I think when they were started in the 60s and 70s, they really served a purpose of going and negotiating drug costs with health insurance plans. But as we see now, we have got 3 of the largest PBMs that really dominate the market. All 3 are in the top 15 of Fortune 500 companies. And as we try to really unravel the drug supply chain and the costs that end up to the patient at the counter, that's a big role that we really want to just, try to examine and make sure we can understand the whole drug supply chains, the rebates they get from manufacturers, and how they actually get passed on or due to the customer and the patient at the counter. So that's something I think we all agree on is something that we really need to focus on and bring more light to the pharmacy benefit managers. It's happening across the country, and I think they play a big role in healthcare costs. Not that they're all bad, but we just really need to be more transparent in how those rebates really actually get passed on to the patient.
So what I'm hearing is you'll be keeping us in the press corps pretty busy over the next few weeks. And certainly, you two have a pretty demanding job on the Healthcare Financing Committee. Committee does a lot of work. Not only does it start with its own bills, but other healthcare bills get referred to you throughout the course of the legislative session. And healthcare, as everyone in this room knows, is a big deal in Massachusetts. We've got a big, robust healthcare system, robust biopharmaceutical presence. And Representative Lon, one thing I'm curious about is you're new to this committee this session, having come over from election laws, I believe. How did you approach stepping into that role while the healthcare system was in such turmoil during COVID?
So it was a challenge. It was a challenge not meeting with people, not even meeting with your co-chair or your committee members, except on Zoom, which is a challenge. I think COVID dominated so much of the early part of session that we were, daily just trying to figure out what was the challenges that our health and hospital systems faced. During the Omicron surge in January and February, I tried to get out and visit as many hospitals as I could over a month period. Went from the Berkshires to the Cape to Boston hospitals, Central Mass. Because as much as you can hear, and having a wife and listening to her stories, and the challenges that they were all facing on the front lines, to be able to go to emergency rooms and see the ER boarding, seeing kids for weeks boarded in ER, seeing the staff have to deal with mental health issues while they're trying to provide care was really eye-opening for me. The speaker got out and visited many. We have been in touch constantly with our hospital systems. We know that many of them are really financially in rough shape coming out of COVID, so we're really going to have to continue to work to stabilize our hospital system. But being out there and on the front lines and seeing actually the challenges of not be able to move people out of a hospital to a skilled nursing facility because they had workforce challenges or no beds open, really created this really bottleneck at our hospital system. And, I don't think, you hear, people who, and friends who don't really, criticize, government's response to COVID. I think there was no playbook, there was no end game, and I'm not sure we still can really say there's an end game, but we do have obviously a better handle on it. I think we really need to invest more in our public health systems throughout the Commonwealth. We showed, as the Senator mentioned, the social determinants of health, who got left behind. It was, people in rural areas and people of color. We knew that existed. Hopefully, we can do and work to make sure that we, provide support to those safety net hospitals. That is a big concern of the Speaker. That has always been something that he has shown a great interest in making sure that these safety net hospitals and community health centers are there for those people who really need them. So I think it's really been a challenge. It's been much better to have people in person and be able to have dialogue with people not on Zoom and really get into a back and forth and in-person meetings has been helpful. But so I just think it was a difficult time to start in this position. Senator Friedman's been a great partner and very helpful, and her obviously serving as Senate Chair was very stabilizing, I think, for all of us, and she's been a great partner, and it's been a good experience, but it's certainly something that we're just going to try to keep working and finish the session strong, and the things that we agree on that we can hopefully move forward that will really make an impact on healthcare and patients here in Massachusetts.
Great, and Senator, you've been in this role pre and during pandemic, I guess. What do you see as having changed?
I'm not sure that things have changed as much as they have become clearer, that what existed, the issues that existed before the pandemic have been exacerbated. I think the sense of urgency that I feel has changed, both because I think people are in such turmoil and a lot of people are in pain, but also because this is a moment, right? And we, so much comes at us, it's hard to remember what happened yesterday. And so I think it's incumbent on us to grab moments when we can, and I think now is a good time to try and grab those moments and make the changes that we can. I mean, it's an incredibly complicated system, as everybody knows. It's ridiculously, inefficiently complicated, and we're trying to navigate our way to good quality, good access, and cost. And as these problems come up, we need to decide, okay, which ones can we address now, and they will make the most impact. So that's kind of what I think is the sense of urgency has changed for me, and there's been a real clarity around what some of those very big ticket items are for people that we should be addressing.
Great. And Senator, you mentioned, and as you say, it's no surprise to anyone that this is a very complicated system. How do you, as a legislator, as someone who's trying to make policy in this space, how do you balance the competing interests at times of, say, patients, insurers, hospitals, providers, drug companies, all the players I'm forgetting to mention in this space?
So the way the best way that I can frame it in my mind is that it's this onion, okay? And it is an onion because as you peel it, it kind of gets stronger and stinkier maybe. So, we sort of have two options. We can either blow the whole thing up and go to single payer, and that will solve a lot of problems and create other problems, right? Or we can try and deal with the system that we have. And the way that I look at it is like an onion. You start at the outside layer and you say, who are the fundamental stakeholders? And in the middle is always the patient, always the patient. And you look at who are those stakeholders. Well, it's payers, it's providers, it's pharmaceutical companies, it's PBMs, it's imaging, it's the people in the business of supporting that. And so you sort of walk around the outside of this onion and say, okay, what can we do in this space to make it better? What can we do in this space? What can we do in this space? And you move around that onion, and you get around that first peel, and then you say, okay, that's what we can do. And you rip it off, and you go to the next layer. Okay, now what we can do? Now what can we do? What's the next thing that we can do to ensure the patient, the person in the center, has the best health care at the most affordable rate? And that's what we always have to be looking at, is who are we doing this for and what are their issues? And the issues are quality, accessibility, and cost. And so the only way that I can frame it in my mind is to sort of take this approach of one layer and then the next layer, and it really means that everybody has to have skin in the game. Everybody's right and everybody's wrong, and somewhere in the middle we're going to find the best solution. It won't be perfect. It will never be perfect. The system's too big to have it, work for everybody, but we can keep working at that, and we can keep looking at what's going on for people now, what are the issues now, and we haven't quite gotten around to that first layer of the onion. We got to get pharma in there. We've got to get PBMs in there. We have to understand what these true cost drivers are. And we can't sort of hide anymore behind, well, that's too complicated, or this is proprietary, or the ability to point fingers when we don't have data and we can't say, wait, stop. Let's look at the data. So that's what we have to do, and that's the only way that I can look at it. Otherwise, it is way too overwhelming and way too complicated.
That's great. Representative, I don't know if you have a corresponding vegetable-based metaphor. What's your approach to seeking out solutions here?
Well, Senator Friedman's right. It's a very, as a not so famous president said, who knew healthcare was so complicated? And, like her pharmacy bill, which we all want what she wants. It's just how do we get there, right?
It's in the bill.
But, I live in a district that has, in her as well, that has incredible innovation, right, going on in drugs. And, there are high-cost drugs that treat very rare and very rare cancer, that really have incredible outcomes that target very small populations. So our balance in government is making sure we know 9 out of 10 drug trials fail. We don't want to stop innovation because those rare drugs that help a specific small part, and I know that's what she wants. We agree. It's how we get there without disrupting and making sure we don't stop that. And I know that's not what she wants. It's how do we get there? And that's the challenge. And just in talking, I think, as we mentioned about PBMs, those definitely are something that is on the radar nationally as a high cost in drugs and the whole pharmacy chain of how drugs are dispensed and how local pharmacies, how that comes to the counter. And there's many issues in there with spread pricing that we really need to get our hands around and make sure that we understand how that actually in rebates get passed on to the health plans and to the patients, because there's a lot of money in that chain that we really need to kind of focus on. But that balancing act of innovation and making sure that we do not stop. And we know here in Massachusetts that is a big driver of our economy. We have seen, in my district, I live in Watertown, whether it's biopharma, lab space, it is bursting. As we know, Cambridge is pretty maxed out, and we have some incredible jobs and incredible innovations. We know from the COVID vaccine, that came from Boston. Our hands were in all of those vaccines. We live in the best place in the world for healthcare, but we've got to continue to strive to make sure that our healthcare is accessible and affordable for all people in Massachusetts, and that's the challenge.
It certainly is a challenge. I think we're in a pretty good position to wrap up and leave it there rather than diving back into the weeds at this point in the morning. But if either of you would like to offer a final word, feel free.
Sure. Just again, thank you for having us. And I know Speaker Mariano, my colleagues, all will continue to work with Senator Friedman in the Senate and the administration to bring as many of these things that we can agree on at the end of session that will really have an impact on the quality of life of people here in Massachusetts. So thank you.
Thank you.
Yeah, thank you for having us. And I want to echo what Chair Lon said. I think there's a lot of common ground, and I think it's not from lack of people caring. It's just trying to move forward in a way that makes sense and doesn't make the system worse. Although some people may say you can't make it worse, it's just go for it. So anyway, so thank you for having us.
Thank you both for your time. I look forward to seeing what comes out of the next 5-ish weeks of session and beyond.
We are too looking forward to it.
Going to be thinking about onions the rest of the day, and hopefully so will you, constructively. We're going to turn now to the adventures or misadventures of the legislature, to the wider landscape, which, as you know as well as anyone, is incredibly complex and challenging. Hospital financing, the big players and the small players, community hospitals, prescription drugs, some of the issues that we've already been talking about, but now let's hear from the industry. Now, of course, we have this wild card too, this overlay of abortion access, payment, out-of-state issues. It's really just a striking moment to convene. So I'd like to call our second panel, and so that you know who they are. It's Laura Pellegrini, whom I've known for a number of years. Let's put it that way. The president and CEO of Mass Association of Health Plans. Amy Rosenthal, the executive director of Healthcare for All. Tom Sequist, the chief medical officer of Mass General Brigham, and Michael Dandorf, the president and CEO of Tufts Medicine, which is, again, if I may wax impressed, kind of blows me away. I'm really looking forward to it. The first panel was great, and I think we are in for more of the same. So with that, I'd like to invite, Jessica, forgive me, our moderator, Jessica Bartlett, of the outstanding medical reporter of the Boston Globe, who will lead us through some of these issues. And again, forgive me, Jessica, and we will wrangle the microphone and be underway.
Yes, okay. Wrangle myself from this so I have wiggle room. Well, thank you so much all for being here. This is an incredible panel. I'm excited to moderate. I wanted to start by letting you all introduce yourselves. So, I think everyone in this room knows who you are, but just in case. Michael, let's start with you.
Sure. I'm Michael Dandorf. I'm the president and CEO of Tufts Medicine, Tufts Medical Center in Boston, Melrose Wakefield, and Lowell General hospitals out in the community, home care company, and a large hospice network, and a network of just under 2,500 physicians overall.
Thank you. Laura?
Laura Pellegrini, President and CEO of the Massachusetts Association of Health Plans. It is wonderful to see everyone this morning and to be here.
Thanks. Amy?
Hi. Ooh, that's really loud. I'm Amy Rosenthal. I'm the Executive Director of Healthcare for All. We're a consumer health advocacy organization that does direct service work as well as policy work as well.
Excellent. And Tom?
Morning. So I'm Tom Sequist. I'm a primary care physician at Brigham and Women's Hospital and the Chief Medical Officer of Mass General Brigham.
Excellent. Well, thank you all for being here. I want to start with the table setting. So COVID has seemed to disrupt a lot of the way the healthcare system works. We had a surge initially that delayed care for many people, worsened healthcare problems, caused all this financial catastrophe at kind of every level of the healthcare system, including with patients. And so I wanted to first get a sense of where we're at financially. Michael, let's start with you. Is the hospital model broken in some way in that every surge that happens seems to set health systems back financially? They spend the next several months kind of crawling out of that hole, and then seemingly another surge hits. How do we kind of get out of that cycle, or is this just kind of the challenge of the moment and the model isn't fundamentally flawed?
Yeah, I would say that the model needs changing and tweaking and evolution overall. As you said, in the surges, two things happen. One is we, as a hospital industry, we forego some of the more profitable services, which are elective services, where people are scheduling those. And in each surge, we've been asked to curtail the number of elective procedures that we do, which for the hospital industry alone is where most of the margin gets generated overall. We've also seen this incredible stress on our workforce, our physicians, our nurses. We talked about burnout earlier, and I'd like to say that we had a burnout problem and a stress and burnout problem long before the pandemic. The pandemic made it much worse. The suicide rate amongst physicians was twice that of the national population, as an example, all related to burnout overall. So what we've seen is staff leaving the industry because of basically 3 pretty significant surges that we experienced. And as a result, we've had to increase the cost of labor or contract for certain labor at a much higher cost overall. So it's that combination of decreased revenue and increased expenses that has really impacted all hospitals across the Commonwealth, and for that matter, across the country. I haven't spoken to a CEO in any other market that hasn't been impacted the same way.
And Laura, how do you perceive the healthcare market from an insurance perspective? Do you agree that it's broken? And if so, I mean, a lot of these things are financial in nature. How do we afford to fix them when patients, and I'm going to get to this with Amy, are already paying incredible amounts that they say are unaffordable?
So first of all, like our frontline workers, I can't say enough about their courage during the pandemic. Particularly those early months were so scary. So to all of them, really thank you. And thank you to the federal government and our state government, Governor Baker, the House and the Senate, who really put money on the table to ensure that our hospital system was viable, particularly during the year of 2020. And interestingly, the hospitals did end up on average with a 2.6% surplus at the end of 2020. In 2021, on average, they were about 5%. The plans were at 1%, which is fairly typical for the health plans. They make about 0.5% to 1% surplus in any given year. So I think that there are a lot of challenges that are facing the hospitals. Unfortunately, my mom right now is in the hospital. She's been there about a week, so I call this my field work. When I go to visit her, I talk to the nurses. It's definitely a lot of nurses and have left the practice, left the bedside to do other things, and they're being filled with traveling nurses who can be very expensive, or with recent graduates who probably are less expensive. So there's a lot of things going on in the hospital, and I don't envy either of these gentlemen for the work they have to do. But I think we need to, drill down on labor costs, understand what's going on in the hospital system. Are these costs really soaring? Are we paying less because we're taking some folks right out of school? And, look at all of that, and then look at our hospitals. We've got the best data in the country, right, around finances. And so we sometimes draw a broad brush, and not all hospitals are created equally. Mm-hmm. We do have some hospitals who have high Medicaid penetration, who have had negative margins, but a lot of our hospitals have been able, through federal funding and support and state funding, been able to come through the pandemic. And I'm hopeful that we're on the other side of this. Just the fact that we're together this morning. 2 years ago, that wouldn't have seemed possible.
Without masks on, can you believe it? So as insurers enter into negotiations with health systems who are likely to come to the table asking for more reimbursements to make up for the gaps in the last year, or to anticipate the costs they say are coming, even if they're financially well positioned, I'm curious from a consumer perspective, what is at stake here? Set the ground for us of the affordability of the system as it exists now. How much more can we truly afford to give to the system? I mean, that's already, Medicaid is what, 40% of the state budget, and that's just on the state level. So talk to me about where things sit from a consumer perspective.
Yeah, so obviously things have been very challenging for the hospitals. I'm the wife and daughter of pediatricians, and know firsthand the challenges that we've had. I think as stressful as things are for industry, we have to remember they're equally stressful, sometimes more, for the individual families who are going through a medical crisis, who are trying to get care, who are trying to afford that care. We have a consumer helpline at Healthcare for All. We take about 25,000 calls a year. We now take it in 5 languages. We hear every single day about issues around healthcare affordability. People unable to afford their prescriptions, unable to afford their health insurance, unable to afford a medical bill. I think when we think about affordability, we have to think across the board at all the different ways in which individuals are absorbing costs and how we can try to bring down those costs. To Senator Friedman's onion piece, I think when you think about it, when you're the consumer sitting in the middle and you're paying all of these different bills, how do we work on bringing those all down for the consumer so that they can get the care that they need and benefit from the incredible healthcare system we have here in Massachusetts?
Yeah, the onion metaphor is especially apt because at the center of the onion it makes you cry. So I don't know if that was intentional, but it certainly works.
We get a lot of that crying on the helpline, unfortunately.
Yeah. So Tom, is the answer here, or is there more federal or state funding that is needed to either prepare for the next surge that might be coming? I don't want to be Pollyannish and saying, well, maybe we're done with surges in the best case scenario. Because every time we say that, another one comes. The variant is, or the virus is ever evolving. So how do we kind of pandemic proof for what comes next while we're still in the middle of grappling with the financial problems of the last 2.5 years?
So we certainly should be learning from what happened over the past couple of years. I guess I would sort of maybe assuage your worries a bit. There will be another, like, we're not, the COVID sort of pandemic is not over, and we will continue to sort of experience these ups and downs. I don't think anyone largely disagrees with that. So we should, but hopefully it won't be, like March of 2020. I think that what we should be doing is learning from, what did we learn from a delivery system standpoint back, going back 2 years ago, and identify what those weak areas are, and then identify very specifically how state and federal governments and other organizations can help us. There were things like, did we feel like our supply chain was totally adequate to meet the needs of our patients and communities around us? When we switched to total digital programs, did we have the infrastructure, the policies set up, the payment policies and everything else that would enable us to actually provide remote care in an equal or an equitable fashion? I think that my concern would be that we don't take that learning forward and inject it into all of our policy decisions that we're making going forward, and then all of our funding decisions after that.
Thank you. I also wanted to talk about something I've spent a lot of time covering and has kind of been the news of the moment before Roe, which was behavioral health care. The exacerbation of a longstanding problem. The crowding of the ERs is kind of the foremost symptom of the longstanding problem, kind of beyond that. Laura, insurers oftentimes are the places where people start first. If it's not the ER, they're trying to look for what services are in network for them, where they could go, what's available to them. Are insurers doing enough to coordinate where people can go, especially after an acute inpatient stay? Or is there something else that needs to happen to better help people kind of navigate this system, which is very disparate and kind of exists in all these different parts?
Sure. So I think, with ED boarding, it's interesting. I met somebody who was an attorney at DMH 20 years ago, and she said, "What's going on with ED boarding?" This was a huge issue when I was at, DMH, and I said, it's even a bigger issue today because of the pandemic. I think that it's really mental health issues. We've sort of touched upon this, been exacerbated because of the pandemic. I think we all have been under enormous stress as we kind of navigated this new normal. Plans have, stepped up and are trying to meet this challenge, but it's enormous and it's multifaceted. It's just not the health plans. We have in place today 24-hour assistance lines for our emergency rooms, try to place patients. One of the challenging things, there are categories of patients that often get stuck in emergency rooms, such as children. So we might be able to find a bed, the hospital might be able to find a bed, but it's too far away from where the parents live. They want their child close by, even if we found an out-of-network placement. So I think we in DMH, and I think Secretary Sutters and her team, I think we know where the bed shortages are. It's just how we get those beds today online. The plans have worked closely with DMH on a protocol on how we should triage patients who come to the emergency room and who are boarding. The plans have taken that very seriously. We meet once a week internally, and then we meet with DMH. I'm really proud that the House has codified that protocol into their legislation. The House and Senate have both done great pieces of legislation. On emergency room boarding, there's a requirement that the EDs actually have behavioral health clinicians available. Just so if you went in for a broken arm, you'd probably see an orthopedic surgeon, but it's not always the case with behavioral health, and you can see somebody from the psychiatric practice. So we're really hardened about that. I believe that's in both bills. So we all need to do our part. It's really multifactorial and multifaceted. I know we're very, very willing to work with the hospitals on this. We've even talked about bringing triage teams into emergency rooms. I don't know if the emergency rooms would like that, but we've talked about a lot of ideas. But we're at the table, and we have increased payments to providers significantly over the past few years as well. And then I can't forget telehealth, which has been a game changer. And there was, I think, a provision, Senator Friedman maybe initiated this in the Senate, to pay behavioral health at the same rate that you would pay an in-person visit, and we supported that. We think telehealth really lends itself well to behavioral health practice, and it's a way to help with access. So we've stepped up quite a bit.
And Tom, from the hospital perspective, experiencing the ED boarding within your ERs or emergency departments, how do you see the gaps? Where are the places that the system most urgently needs to address in order to start to kind of better move people through the system?
So I think the biggest challenge that we're seeing is the staffing, the folks who provide the mental health care, whether we're talking about physicians or nurse practitioners, social workers, and that's a big problem that was present before the COVID pandemic, but just got worsened during the pandemic. And so, the way that we need to address that is not only through wage increases, but it's also making sure that we create a sustainable pipeline, so trainees, like developing the careers of these healthcare professionals, and then also once they're in the field, like creating a sort of a way that they see a professional career advancing in front of them, so that it is not a field that they're going to leave, briefly after the investment of their time and the training to get to the place that they're at right now. And I think that that's all of that is in the sort of bubble of like all the burnout that everyone is experiencing. So patients are coming, obviously, the mental health crisis was worsened, but the providers themselves experiencing a lot of burnout, as you were saying before. And so, one of the ways that we can combat that burnout is by creating this good professional career pathway for them. And that's a lot of work. That's not a 3-month solution, but it's the pathway that we are going down to try to address this.
Mm-hmm. And Michael, from the perspective of the hospitals as well, if staffing is such an issue, from every level, really, not just for inpatient beds, but therapists, psychiatrists, even if the system adds more beds or even if the system in the aggregate adds more inpatient beds, how do hospitals start to grapple with, well, how do we staff them? And how do we staff the things that keep people from the hospitals to begin with, the primary care, the other tendrils that keep things from becoming acute?
Sure. There's, I think, Madam Chair Friedman sort of talked about the complexity of our financing mechanism. And I think this is true in behavioral health as well, is thinking about, are we putting enough resources in the right areas to support proactively trying to keep people out of inpatient settings, into outpatient settings, into the home, thinking about telehealth, as Tom talked about. We've seen from a behavioral health point of view, and really in total, the adoption of telehealth in the beginning of COVID skyrocketed. And even nationally, when you look at the national numbers, and we're seeing the same thing here, is on average most specialties have come down to that 15 or 20% still being delivered on telehealth, whereas in behavioral health, that number's staying at about 75 or 80%. One, because the consumer likes it better, too, than having to walk into a building and the stigma associated with that, So I think we do need to think about the technology capabilities that could extend the provider base more. But I don't think we're going to get away from we need to put more resources there. We do need a different workforce. We need an extended workforce. We need an integrated workforce so that behavioral health is integrated in the care processes overall. And I do worry sometimes that every segment of the industry has its own solutions. And we all need to come together, and Senator Friedman talked about this in terms of not addressing component by component, but how do we actually all come together and look at the system in total and think about behavioral health in that context, because it's an important and increasingly important part of the system. And while I hope that a decade from now we don't need the number of inpatient behavioral health beds, I don't think that problem is going to go away in the short term overall. And we're going to need to proactively think about how do we develop the workforce to staff those additional beds overall.
Amy, what are the patients saying when they call into your helpline? Is it access of inpatient beds? Is it accessing therapists? Where do you see the gaps? And also, how, from your perspective, has it gotten this bad so quickly? Is it all the pandemic's fault, or has it just been a escalation.
Yeah, no, I mean, this has certainly been an issue, as others have said, before the pandemic, and it's just exacerbated, particularly as we think about kids. I think the point about integration is absolutely essential. Really, we do a lot of work on thinking about pediatric behavioral health integration into the practices. Mm-hmm. I think that's essential. I just think that we have the roadmap that the administration put out. We have the 2 bills in the House and the Senate. We have real opportunity to move forward, and I think everybody needs to continue to do more. I spent the weekend with a friend who's a clinical psychologist, and she was talking about the number of hours she spends as a private practitioner dealing with billing and how complicated that is and how it takes time away from her patients. I think we need to think about that. There's, the ED boarding issue obviously is huge. Thinking about annual mental health visits for people so that they can get kind of a checkup in the same way that we do with primary care. These are all things I think are in the bills. I think we need to see something get across the finish line, and so that we can start to tackle some of this.
Yes, fingers and toes crossed for the next 5 weeks. No pressure. Laura, are insurers having these conversations in regards to, they've already, as you mentioned, stepped up, have done a lot of things, have increased reimbursements, have paid behavioral health, telehealth at parity. Are there other things insurers need to do to reduce the administrative burden, to clear credentialing? That's in some bills, but why haven't they taken the proactive steps to...
So credentialing was solved on the commercial side like 15 years ago. I think the governor recently was like, didn't we do this? This was done like 15 years ago on the commercial side. We have a not-for-profit company that works as a clearinghouse where there's a uniform form. Providers can fill it out one time from multiple insurers. That company then does the verification to get folks up and running, and then the plans approve them for their network. I think Mass Health, because of some federal requirements, has not been able to be part of that. So that's credentialing. I think on prior authorization for all of you is very important. You may not think that, but it's a safety issue. So my mom, like years ago, somebody gave her an MRI after colon cancer, and they're like, your mother has liver cancer. For some reason, I got a second opinion. We went to the top specialist in Boston, and he said, I don't like to rat out other doctors, but they shouldn't have given your mother an MRI. They should have given her a CAT scan. Her CAT scan's negative. Her MRI is positive. So you need to now come back here every quarter for the next 2 years to see if anything changes. Right after that, Harvard Pilgrim, I think, was the first plan, I was there, to initiate a soft denial. That when folks wanted imaging, everyone wanted to throw somebody in an MRI machine or a PET scan machine. Those were the 2 hot machines that were very expensive, so everyone's going to get one. Prior authorization was used to ensure the right test at the right time. So it's a safety issue. But prior authorization, I hear about paperwork, right? We need to automate that. So we are very supportive. We're working today to automate prior authorization. If we can all work together on that, people can have a yes answer in 8 seconds, right? So that's something we need to work with. I would hope that MHA and we could actually, rather than be at loggerheads on a lot of issues, really think about ways we can make healthcare simpler. I served on the governor's digital health task force prior to the pandemic. We talked about how can we bring all these electronic medical records together. And so physicians would have that. So my mom now is in the hospital. They did a CAT scan. There's something on the CAT scan. They're not quite sure what it is. I'm like, can we get one from Beth Israel? Like, they're going to have to go and do some legwork to go do that. Think about if we had a clearinghouse where everyone's medical records were available, how much easier that would be and how much time it would save physicians. So we're having those conversations. They're very important. Getting back on the BH thing, I just want to say we were very supportive of the governor, and I think Senator Friedman talked about this, about how we realign some of the spending in healthcare. And so the governor wanted to really prioritize primary care and behavioral health. I think we see that as the backbone of the healthcare system, and particularly after the pandemic. And so what that means is probably a takeaway from some of the specialties. We think that's an important conversation. We've been talking to Senator Friedman and Chairman Lawn, and that's probably for next session, but it's something we should continue to talk about.
Are prior auths a safety issue for every single type of care? Like, are insurers willing to eliminate prior auths for some behavioral health care, inpatient stays? And
we've eased up on some prior authorization, but I think what the plans do is they look at their claims, and if they're seeing inappropriate, so that's what we saw with the technology, inappropriate utilization. I'm going to, another story, so I've been doing this like so long. During the opioid crisis, which is still ongoing today, that is not over, right? We were talking about MAT services, that patients should get methadone, Suboxone, one of these drugs, and they could do that in an outpatient setting. I remember when I spoke to people about it, it was like heresy. Like, you just don't want to pay for an in-person visit, hospitalization. We're like, that's not ASAM's criteria, evidence-based practice. We should be moving to MAT services. Today, it is widely accepted that MAT services are the appropriate treatment. In a lot of hospitals, I think Mass General does it right at the emergency room. They start that treatment right then and there. So prior authorization, again, is trying to bring the practice so that it's evidence-based. Drug companies don't like prior auth because they want you to use the drug that they're advertising on TV, even though it may have tons of safety problems, and there's a drug that is more safe, maybe a generic, that you could take. So that's why we use it for quality, safety, and obviously cost is a piece of it too.
I wanted to also talk about health equity. Amy, how do patients experience inequities in the system? I mean, are they aware in the moment that things are inequitable, or is it just kind of accepted by them that this is just how it is because it's been this way for so long? Like, is this top of mind for a lot of patients, or how are they?
I'm so glad you asked me about health equity. Before I do that, I do just want to say on prior authorization, though, that I appreciate why it's needed, but I would also argue that we get hundreds of phone calls from people who don't know how to navigate and deal with the prior authorization. They maybe have a chronic condition and they have to keep going back for prior authorization for medicines that they take continually. And so I do think that there's still a lot of work to be done prior auth. In terms of health equity, I would say I'm so glad you're bringing this up. There's so much that needs to get done. There's definitely a huge sense of, frankly, injustice from people that we talk to. I think that there's lots of good people in the healthcare system who want to address these issues. I think we just need better strategies to be able to do that. There's a number of bills and legislation that we can be doing and things that we can be thinking about in order to address it. So just to name a few, in today's paper, Marcela Garcia focuses on the life of Dylan and his mother Ruth, who are two individuals who are unable to get mass health for their child because of their immigration status. And so there's a Cover All Kids bill, which we really believe would get at some of these health equity issues to make sure that children have access to prescription drugs, have access to medical equipment that they need, and others. There's another big initiative right now, the Health Equity Compact, that Michael Curry and others have been leading. Lots of people are involved with that. Healthcare for All is really eager to stand with the compact and figure out in the next legislative session things we can be doing. I also think that there's things in the prescription drug bill that Senator Friedman has done and others where we think about reducing or eliminating copays for chronic conditions that disproportionately impact people of color, things like asthma and heart disease and diabetes. There are tangible things that we can be doing right now to make sure we're really getting at health equity and really making sure that people can afford the care that they need, which we know disproportionately impacts people of color as well.
Tom, we've spent so much of the last 2.5 years, within this racial reckoning, identifying the disparities, saying like, look, here's another one, but how do we move, especially health systems, move beyond just identifying the disparities into actually changing them?
So 2 seconds on prior authorization.
Oh, I didn't know it was such a hot topic.
It's a hot topic, right?
It's really important that we don't want to, in the field of quality, we would call this overuse or inappropriate use of and of course we all want to support that. The bottom line is, though, the science of quality measurement in overuse is not as well developed as the science of quality measurement in underuse. Like, you didn't get a mammogram and you should have. We're very clear on how to detect that and how to promote that. We're less clear on should you use this medication or not when you apply it to 1 million patients. And that is then, and so when we think about interventions that we make in the quality improvement space and we think about error rates in our interventions, the error rates on overuse measures are high. And so when you look at the data on prior authorization and like, are we actually reversing care or making changes in care decisions, the percentage of time that happens is likely relatively low because of the inability of our science of quality measurement to actually provide effective interventions in that space. And then that's why it leads to every time you do burnout surveys among providers, that prior authorization ends up high. It's because of our inability to actually design a highly effective intervention. So I'm sorry, I'll get to the equity.
I want to, now that we're on prior authorization again, because to Laura's point, while it is cumbersome and ultimately, lands on the patient in some way to navigate this system, it is also a constrainer of cost. And hospital systems, are currently undertaking things that the Health Policy Commission would deem as like low quality care. So how do health systems establish the trust that the things they're prescribing are actually needed, are not low quality, in order to allow insurers to say, okay, then we agree with you that we shouldn't have to double check your work and pay for it as it is?
So absolutely, and of course the hospital systems support the notion that we should be reducing costs. It is very tightly linked to access to care, which then is linked to
no access if it's not affordable.
Right, and so and obviously that then is linked to something that is close to all of our hearts around equity across our state. What I'm suggesting though is when you develop an intervention to lower costs that's at the clinical decision making spot, that we have to make sure that those interventions are reliable and accurate. That's the problem that leads to the burnout issue. It's not that we shouldn't be questioning whether we're making the right clinical decisions on behalf of our patients, because of course we should. It's whether or not we have the science developed well enough to actually make the intervention at the right time.
That's fair. Actually, while we're on this, I'm going to ask Mike a question as well. It seems too, correct me if I'm wrong, that a lot of physicians take tests and do additional things as a measure of self-protection from malpractice claims or allegations that they didn't do enough. And so how do physicians, use healthcare effectively and efficiently without going too far, that then ends up in this kind of prior auth quagmire that we've been discussing?
Well, I think it goes to what Tom was talking about in terms of how do we aggregate data in major populations around what is that evidence-based practice. But let's be honest, the amount of money that we're spending on administrivia is enormous. And if we were able to reuse those dollars in a meaningful way, we could start to close some of these health equity gaps and the other things that we're talking about. But when we've measured the amount of time that our providers are spending going through the prior authorization process and the fraction that actually wind up where they're told no is pretty darn small. So like 98.5% of the things that we're trying to do that require pre-authorization ultimately get approved. But we spend a lot of time in that. We have 700 people that are managing our billing and payment process overall. We shouldn't have to spend that much because of the complexities of the system. Overall, I don't think it's gaming. I think it's just there's a lot of complexity that we've built around the system. The rules, payer by payer, make that challenging overall. Not everybody follows the same prior authorization schedules. Different payers require different things to be authorized. So if we're really going in evidence-based practice, how come the payers don't have a common set? Why aren't the rules the same across all payers? They're really they're very, very different. The billing requirements are very different. So I think we got to think about how do we really reduce that administrative burden in a meaningful way and repurpose the use of those dollars in ways that improve the health of the populations that we serve overall. And it gets to the equity issues because I was listening to Senator Friedman, and the desire to try to keep this the macro dollars that we spend on healthcare sort of net zero. And I think that's going to be difficult in the short term. I think there's going to need to be certain investments, but we need to think of healthcare more broadly. It's not just medical care, it's not just hospital care overall. We talk a lot when we talk about health equity and health disparities around social determinants of health and the need to make certain investments, societal investments, that are investments on the front end that have long-term effects. Because the reality is we know some of those health equity issues are along racial lines and ethnic lines, and they tend to be along poverty lines. So when you look at this not only here, but around the country, there's really a correlation between those things. So that means that we have to elevate the economic status of some of these more vulnerable communities. And that means investments in education and investments in public health in different ways, so that we could really sort of get over that chasm of some of those health equity issues. Overall, it's not just a provider issue, it's really a societal issue. And it's going to require us to get together from a public-private partnership point of view. You know, what role does industry have in that? What role do insurers have in that? What role do providers have in that? What role does the government have in that? We all need to collaborate and figure out a better way than what exists today.
Laura, you wanted to make a point?
I'm good.
I mean, to follow up on that, while everyone has to have a seat at the table, how much are health systems willing to kind of put their skin in the game? Because that's where the highest amount of spending happens currently. I mean, drug prices are going up the fastest amount, don't get me wrong, we'll get to that. But outpatient care has gone up precipitously year over year, and hospital spending as a category is exceedingly high. And so how do we, you know, if everyone's sitting at the table but hospitals are spending the most, how do they kind of come and put skin in the game to say, well, then let's redirect the spending?
So we're 100% willing to get into the game and put skin in the game, and the insurers need to share that risk, you know, in terms of what we call value-based care, sharing of the premium dollar in a way that we all are aligned from an incentive point of view. There's a few things in your question, and I want to come back to some of the data that Laura mentioned, because I was actually just looking at this last week. When we look at the industry of healthcare, biotech, pharma, insurance, and providers, when we think of the last couple of years, the providers have been on the front line, really caring for patients that are very sick, showing up with COVID. And we know that there's been delayed care, and we're now dealing with those crises as well. At the end of 21, we've seen a degradation in significant degradation in terms of providers' margins. You look at it across the state, every health system right now is losing money. Now, is that a short-term thing, or are we going to reverse course on that as we get staffing figured out and those sorts of things? Absolutely. But we look at the health plans, their margins have been higher than ever. You look at the Massachusetts health plans, just because you brought it up. If we look at the Massachusetts health plans, the recent data that I've seen, at least that came out of MHA in the analysis, about $1.1 billion in margin in 20 and 21, which is higher than the previous 5 years altogether, comprehensively. The medical device industry has made, in those 2 years, between 15 and 20% margins. The pharmaceutical industry has made between 20 and 25% margins. The biotech industry has made between 30% or so. Providers now are making anywhere near those margins overall. Now, the cost of hospital care and the alternatives in terms of thinking about changes are going to require us to think about how do we think about pre- and post-acute care, how do we start to align the incentives so that we really do lower the utilization of inpatient services. I think there's an opportunity there that we need to go at. And I would almost advocate that we bring, in Massachusetts, I'll call it a blue ribbon panel, I've said this once before, of insurers, providers, post-acute providers, public organizations, the government, and really start to think about that collectively, and not one by one or issue by issue, but try to tackle these things in total, because the complexity of the health system, the analogy of an onion was used before. I think of it as a Jenga puzzle, right? As we try to change one little thing, we risk the collapse of the industry. And we really need to be thoughtful about, it doesn't necessarily have to be all blown up, but we need to be thoughtful about all stakeholders coming together.
Laura, I wanted to give you an opportunity to respond. I mean, insurer reserves have been the target of hospitals in the past. I know you guys gave large rebates because no one used healthcare services in 2020. But how do you justify the high reserves at a time when the system is kind of hemorrhaging money?
Well, I think it's a fundamental misunderstanding, really, of what's going on. I'm going to read you the figures. In 2020, which was a tough year for the hospitals, on average, they made a 2.6% surplus. A lot of that came from the federal government and state government, but They weren't in the negative. Health plans made 2.5% increase. In 2021, hospitals, this is all state-reported data, 5.4%. Plans at 1%. Plans make 0.5% to a 1% surplus in a good year. Let me explain to you the accountability as well, only on health insurers in the state. We have to give rebates to consumers on a rolling average. So in 2020, if plans made more than they should have, exceeded MLR, they have to return rebates to consumers.
Medical loss ratio.
Medical loss ratio. Sorry about that. So we're held to strict MLR standards, the strictest in the country.
Which says you have to spend, what is it,
88% on medical care.
12% on administrative care, the rest has to be
Right,
on
but
medical.
and everything in the health plan world is very specific of how we bucket these costs. We can't just decide how we're going to bucket them. They're prescribed by the federal government and by our Division of Insurance. So care management is an administrative expense. Everything we're trying to do in IT is an administrative expense. If we make more than a 1.9% surplus, we could have our rates rejected at DOI. And if our RBC is something over 700%, we are subject to a rate hearing or a hearing before the Division of Insurance.
RBC for those?
Risk-based capital. So that would be the money that we in
Surplus.
We were looking at other states. States' insurers have thousands of percent in RBC. It has been stunning to me that the Hospital Association a few years ago took a run at the health plans to take health plan reserves. Health plan reserves are there for patients and they're there for the providers. When Harvard Pilgrim went into receivership, unfortunately I was working there, and they didn't know what to do. Should they close it down or have somebody buy it? The biggest concern that the Attorney General had that allowed Harvard Pilgrim to then work it out was they were going to take 3 hospital systems down with them. Reserves are there to protect patients and to protect the providers. This is not, I always think of Stuart Altman saying, like, the health plans are not the ATM of the hospitals. We have a job to do. We did that job during COVID. We relaxed prior authorization. We stood up telehealth in a few short weeks. I worked hand in hand with the hospitals to make their lives easier. There are some issues that exist today. We've got to solve those. I think one of the questions, and it was asked to me by a leader, is how does Tufts Medical and Lowell General provide excellent quality care at much lower prices than so many other institutions in our state? That's the real question. How do you do the job you do at much lower prices?
We don't make those margins, one, that's for sure. But we have focused just because of some of the rate differences. Medicaid, fixed rate environment, Medicare, fixed rate environment. The only variable is on the commercial side, right, overall. So we've been forced, because we get paid less by our commercial plans, to manage at a lower rate. But we didn't generate those kinds of margins during those years because we're trying to keep our costs low, which require us to manage our expenses at a lower cost as well. And we have been able to keep our quality metrics above the norm nationally, as well as in Massachusetts overall. We're very proud of that. It's one of the reasons we want to move more aggressively into value-based care, because we do think that combination of affordability, quality, and access are things that could differentiate us as a provider overall. But we do need to think about how do we use the resources across all segments of the industry. Are we putting those to the best use for the consumer, to make sure that we keep quality high, to make sure that we address equity issues, to make sure that we have access in the community closest to home as we possibly can, and above all, how do we make sure that there is affordability? You know, when I got here in late 2020, I was startled to learn that the cost of medical care in Massachusetts is the 3rd most expensive in the country overall. And when you look at a lot of the metrics, particularly around the provider side metrics in terms of quality, it runs about average in terms of the nation overall. So I do think in the long run, costs are something that we need to lean into and we need to fix. We're probably going to need to make some front-end investments in order to sort of get to that. But we do need to go after it as a Commonwealth. We need to go after costs. But let's make sure that we're putting the resources in the right places.
Yeah. Well, if you do convene a panel, just let me be in the room. I won't say anything. I'll just sit there and listen. but I'd love to be a fly on the wall. Please.
I was just going to say, yes and yes and yes, which is like all of this needs to be addressed. So hospital inpatient and outpatient costs before the pandemic were very high. We saw that every year at cost trends. That has been an issue, and particularly there are some institutions that cost more than others, and we need to be looking at that. Premium retention was 35% higher between 2019 and 2020 for the insurers, and yet rates increased 7% and 8% respectively in 2021 and 2022. So it's both of those things, and it's looking at prescription drugs where costs went up 8% during 2020. So I think what we need to be really doing is thinking across the board, across all industry. Just, Chapter 58 happened, health reform in Massachusetts happened because everyone came to the table, put some skin on the game. If we're going to address costs so that people can afford care, like Ira, who called yesterday to the helpline, who couldn't afford his care, we need to have everybody at the table making some sacrifices, listening to each other, and recognizing where we can make some changes.
Right, because at the end of the day, if everyone's pointing fingers at one another, the person holding the bag is the patient.
Right, we're just like standing there like, hey.
Right. I do want to get back to health equity. I know we're running out of time. Tom, to kind of get back to this question of health equity, how do health systems hold themselves accountable to actually making change when they've already identified the disparities?
I think in a quick answer to that, and I give a little more detail, but a quick answer is that all health systems have to create a culture of health equity. And the best way to think about this is think about the 1990s and creating a culture of safety. And if we can get our hospitals to the point where they're at with safety right now, which is we do nothing if we think it's unsafe for a patient, whether it's changing out a new IV pump, changing our vendor, or putting in a new care program or staffing ratios, we think about safety first. If you really envision a hospital system that makes every decision through the lens of equity and the way that we make decisions through the lens of safety, then we will have succeeded in a first step of addressing this. These are big issues. I wouldn't say we've succeeded in eliminating structural racism and all the inequities that exist across the country, but we will have, as hospital systems, taken an important first step. Then the second thing you have to do is you have to create really a business plan for how are you going to enact these kinds of changes and hold ourselves accountable to it through metrics and performance standards. So we should say, okay, what are the big blocks that we're going to take on? I think the first big block everyone would take on is access. But we can't simplify access, and we have to say, okay, access breaks down into there's financial access, right? There's cultural access. Do you have interpreters available? Is the building sort of welcoming to your patients? Is your staff diverse enough that patients who come in see people who look like them and feel like they're welcome there? And then there's digital access, right? Do we have the capability to extend that digital arm to our patients? And once you sort of figure out access, then you have to think about, okay, what are the areas we're going to focus on once patients do have access? And the first area we should never forget is chronic disease. COVID was horrible in so many ways, and seeing 2 to 3-fold mortality rate increases among Black or Native American populations is horrific. However, it's really important to note that during that 2020-2021 period, the rates of inequities and deaths from cardiovascular disease went up. And that was sort of the silent thing that happened throughout 2020 and 2021. So we have to redouble our efforts and say, okay, what's the leading cause of death in these communities? And the leading cause of death in these communities has been and continues to be heart disease. And so we have to focus on how do we provide good care for chronic disease management. And then we should start thinking about, okay, well, how are we going to do that? The way we are going to do that is through real investments, and this is not just hospitals, but the whole state and the nation, real investment in the upstream determinants that are producing those bad cardiovascular outcomes. That's food and housing insecurity primarily. So if you put together, and you can put together a real business plan around this and say, how much is this going to cost? And then we can all partner together. And by all of us, I mean all of the stakeholders that are here in this panel today and everyone else across the state. Then you will say, here is my equity plan. But that is a big deal for hospitals, and that's what our United Against Racism platform is across Mass General Brigham.
Mm-hmm. I want to touch briefly, too, on 2 other topics, drug pricing and Roe, because I'd be remiss if I did not. Laura, from an insurance perspective, how do we prioritize the innovation that was discussed at the previous panel with the high costs that are associated with them? How do insurers begin to hold drug manufacturers accountable for the cost they're adding to the system while still allowing the innovation that's so critical to the local economy and to healthcare innovation?
So I often say that a lot of us in this room supported healthcare access. I believe it's a fundamental right. We have to make healthcare affordable. We have an individual mandate in our state. Employers have employer responsibility at the federal level. We have an obligation to make it affordable. Again, I think Tufts is an example. Lowell General, how do they do it at much less cost with great quality? I think we need to examine that. I think for the drug manufacturers, unfortunately, I see a lot of pointing fingers, trying to blame others, PBMs. Sure, we need transparency in the entire healthcare sector. Let's understand the role of PBMs. I would say they play an important role, but if they're going to be the boogeyman of the hour, let's examine what's going on with them. How do you answer that insulin was sold, the patent for $1 20 years ago, it's gone up 1,000%?
Mm-hmm. I believe there's a bill that would address it.
Yeah. So we have to, the state can't do a ton. This is more of a federal issue, but I think the bill that the Senate did, and hopefully the House will take up, begins to address it. We need to hold them accountable at the Health Policy Commission. We need to understand how prices are developed. ICER, which don't ask me what ICER, the group that evaluates drugs and their effectiveness, and if the costs correlate with the effectiveness. When I first came into my job, the drug companies told me everything was going to be great because ICER was going to get up and running. We were going to really be able to do this evaluation. Now they're trying to cripple ICER. The Health Policy Commission and CHIA are the best game in town, right? The inconvenient truth. Data is going to save us. The facts are going to save us. And between the HPC and CHIA, right, we have the best information in the country. People might not like the messages, like you talked about low-value care. If prior authorization weren't, like, why would we have low-value care? Why do we have so many procedures that people are doing that are unwarranted or unnecessary or evidence-based, don't work, right? So we need to hold the whole system accountable. So I think for the manufacturers, I'm not sure I buy that there won't be innovation. The profit margins are huge. They're sky high. A lot of that money comes to them from the federal government, who are actually funding a lot of this research and development. So I guess my bottom line, being long-winded, is pharma needs to be part of the conversation. They need to step up. They need to do the right thing. Sure, this is capitalism. Everyone needs to make a profit, but how much? The health plans in this state do not make huge profits. I've given you the figures. I've given you the accountability. No other actor in the state has the kind of accountability that the health plans have to control cost. That's part of our problem. The hospitals need to have that accountability, and pharma needs to have that accountability.
We're out of time, but I do want to give the opportunity for anyone on the stage to address how Roe might impact your organizations. Are we insulated in Massachusetts because of legislative protections, because of geography, or are you anticipating some kind of change?
Yeah, I mean, I think we're very fortunate here in Massachusetts, thankful that people, the legislature and governor and others have taken steps. For us on our helpline, we get about 1,000 calls a year right now with people who are calling us, either referred to us from service providers seeing if they can get insurance for coverage of an abortion, or from people who just don't know where to turn. I think we're certainly anticipating that call volume will increase in the years to come, and we want to make sure that the funds have the support that they need, that the organizations doing this work have the support they need, that we'll continue to work in partnership with them.
Excellent. Well, thank you all so much for taking the time. This is an incredible panel. Thank you.
Thank you.
And thank you for taking the time. We'll see you at the next one. Thank you all for turning out today.